Yeah, go ahead. There you go. That's gonna be a lot.
All right. Good morning, everyone.
Good morning.
How are you guys? So we will pick up where we last left off and start talking about treatment approach. So generally with tobacco cessation, we really utilize two modes of treatment. So we want to utilize behavioral therapy, sometimes also known as cognitive behavioral therapy, as well as pharmacotherapy, to have the best outcomes possible. And then this is really and truly considered the gold standard. So in tobacco cessation, we always want to utilize that cognitive behavioral therapy, remembering that a lot of these habits that are learned with tobacco use is that, exactly that, it's a habit. It's habit forming until we want to redirect their habits and their associations with tobacco use and with smoking in general. So we want to utilize our cognitive behavioral therapy and then pharmacotherapy to aid in their success. With behavioral therapy, it's a form of psychological treatment that's based on really 4 core principles. It's a physiological problem that is based on a faulty or unhelpful way of thinking, a psychological problem based on learned patterns and habits formed due to repetition, and then learning better ways. Really, we want them to learn better ways of coping with the psychological problems to assist with alleviating the symptoms that they're experiencing. So essentially, we want to figure out how we can reframe their habits and patterns so that they can relearn new habits and new patterns to help aid in their smoking cessation. And this this behavioral therapy is used in combination with motivational interviewing, which we'll talk more about in a little bit. Now, in terms of behavioral therapy, what's really the purpose? It's really a technique used to change the thinking patterns that I discussed earlier. So it's really utilized to recognize the barriers and reevaluate ways to overcome those barriers, to gain a better understanding of the barriers. So kind of what is your patient thinking, what their thought process, and then help identify motivating ways to help them become non-smokers. Next, we want to utilize this also to create a plan for solving that problem. We can help them create new skills to cope with the cravings and barriers to quitting. And then also it helps them develop confidence in their ability to quit as we work through, as we utilize our motivational interviewing and work through those behaviors. Now, we have various techniques that can be utilized to assist with cravings, and we can use the 5 Ds to work through this. So things that we can recommend to patients to help when they have a craving include the 5 Ds. So the first D, delay. So wait a few minutes. Hopefully that craving will pass. Now, waiting a few minutes, I always tell patients we also want to do this in combination with some type of pharmacotherapy agent. And we'll talk a little bit more about that later, but that waiting a few minutes to see if that craving passes is one technique they can utilize. I also recommend distraction. So finding something to take their mind off the craving, something that they enjoy. So for example, I had a patient that was into playing the guitar. I said, well, during those cravings, how about we take that time to work through and you can practice playing the guitar. Those are ways to distract yourself in those moments of cravings. We can also recommend that patients do deep breathing. So sometimes doing deep breathing exercises can help patients kind of take a beat, take a moment, and wait it out. And hopefully with that deep breathing, they can overcome those cravings, especially in situations of stress, because those often are triggers for patients to have these cravings. I also recommend discuss. So I always tell my patients I'm always available for you. If you're having a craving during the day, call me and we can just talk through it. And so if they have someone that they are able to talk to, sometimes that helps take their mind off of things, similar to that distraction, but you can talk through it, whether it's talking about the craving and saying like, this is what was happening and, talking through that from that component, or just taking your mind off of it by talking about something else. And then sometimes just drinking water. So just drinking water takes a beat, gives you something else to reframe, especially if it's that mouth component that patients are used to with cigarette smoking. Drinking water can be another alternative as well. All right, knowledge check. So which of the following is a component of the clinical assessment? Select all that apply. Vitals, B, tobacco use history, C, recent labs, or D, prior quit attempts. B and D? Yep, so B and D, tobacco use history, we wanna have a good history and understanding of what their tobacco use looks like. And then prior quit attempts is really important. That will help you understand what have they tried before, what have they been successful with, and what have they tried and they weren't successful with. If they were utilizing any pharmacotherapy agents, then what side effects did they potentially have that may have been a barrier to them being successful with those previous quit attempts. Perfect. All right, next up is the fundamentals of motivational interviewing. Since you guys have had this previously, this will be a nice review, but we'll go through this pretty quick. So motivational interviewing, by definition, is considered a collaborative, goal-oriented style of communication with particular attention to the change in language. It is designed to strengthen personal motivation, form commitment to a specific goal by eliciting and exploring the person's own reason for change within an atmosphere of acceptance and compassion. So essentially, we utilize motivational interviewing to help that patient realize what their specific goal in their smoking cessation journey is, and understand the barriers to being successful in that goal so that we can take the time to overcome that and create ways that are specific to the patient. With motivational interviewing, when is it really the most beneficial for a patient? Well, it's the most beneficial when ambivalence is high, when confidence is low, when desire is low, and when importance is low, because it can help us understand kind of what are the barriers that they're seeing in this moment, and understand how can we overcome those barriers and talk through what their concerns are. With the spirit of MI, there's really 4 components that make up the spirit of MI. It's evocation, compassion, acceptance, and partnership. So we'll talk a little bit more about that in the next slide, but this is just the general idea of motivational interviewing. With that, the motivational interviewing process, really the fundamental process of this is first engaging. So the foundation of MI is to develop a relationship in which you as a practitioner is listening and understanding, while also providing affirmations and being understanding. Then focusing. So we want to set up a plan that sets an understanding on the purpose of the conversation. So why are we here today? We're here to discuss your smoking cessation. This is the purpose, so that they understand what the point of the entire conversation will be, and kind of will set up the situation for setting our goals. Then we have evoking. So we help the patient determine their why. So why do they want to quit? What is their motivation? And so they can utilize that why as their motivation as they're progressing through their smoking cessation. We always want to reframe back to your why. And we want to find their why by asking questions. So remember, we can utilize those scales that we'll talk about in a little bit, but to figure out kind of what is their goal and what is their why. They may not necessarily in the moment, if you just say, why do you want to quit? Some patients will just say, oh, because it's bad for me. But sometimes there's something more deeper for them. Whether it's I want to quit for my granddaughter, I want to quit for my husband, I want to quit for my health because of X, Y, and Z thing that has happened. There's usually more to it than just because it's bad for me. And then P, planning. So how will the patient make that change? So we want to utilize and be specific about our goals and how we are going to make that change specifically. So with MI, we want to use our OAR skills. So what is OARS? It's an interactive technique that places the focus on patient-centered care that focuses around motivational interviewing. It's both verbal and nonverbal communication. So you want to make sure that you are both an active participant, but also an active listener. All of the techniques that are needed to be adapted to ensure cultural cultural sensitivity and appropriateness. So you want to make sure that you're being culturally sensitive and appropriate when using that active listening and active participation, and making sure that you are paying attention to what the patient is saying. And with the ORS, it's essentially making sure that you use open-ended questions, you use words of affirmation, you use reflective listening, so meaning, what I hear you saying is X, Y, and Z. So we reflect back to the patient to make sure that what we hear them say is what they're actually saying, and it lets them know also that we are listening, and that provides it allows patients to gain trust in you when they know that you are actually listening to them. And then summarizing what you've talked, summarization. So summarizing what you talked about in your discussion that day, so that you can say, based on today we talked about X, Y, and Z thing. Based off of our discussion today, it sounds like our goal is X, Y, and Z thing, so that we can focus in on that and we can give them direct goals that came out of our conversation, and they can utilize that as they continue to progress through their smoking cessation. So going through each of this, so open-ended questions, we want to use questions like, why is it important to you that you quit smoking? So it gives that patient the opportunity to openly ask or openly answer the question with something other than a yes or a no. Then we want to provide words of affirmation. So letting them know quitting is not easy, but you quit for about 2 weeks and that's wonderful. So letting them know that even if you do kind of have a relapse moment, what you did in the beginning, that's great. And we keep utilizing those skills to overcome what may have been a trigger when you relapsed. And then reflection. So repeat, rephrase, and offer deeper guess. So what I hear you saying is that you want to quit, but you are afraid that you won't be able to. Is that correct? And that gives the patient the opportunity to express, like, yes, that's correct. And you can ask more deeper questions and say, well, tell me more about that. And so that we can elicit a better understanding of what their barriers are and what their concerns are. And then summarizing, we want to ensure that there is an understanding between the patient and the practitioner. So like I said, we want to tie it all together and say, this is kind of what we talked about, this is our understanding, and this is what we learned. If the patient has anything additional to add, they can feel free to add that when we're summarizing at the end. We want to make sure that we're attending to a language of change. So discussion is more focused on change rather than the sustained behavior. We don't want to harp on the sustained behavior that they keep having. Like, you are constantly smoking around dinner time. Okay, well, we want to focus more on, well, instead of smoking around that dinner time cigarette, how about we utilize maybe some of your NRT, or we talk about utilize some of those 5D techniques. And then you want to make sure that you have a good exchange of information. This is a conversation and it's a two-way street. It should not feel like you are yelling at the patient, or like you are just talking down to the patient, right? You want to make sure that they are heard and that their concerns are heard, and that you are participating as an active participant, but also, very important, you are actively listening to their concerns and to their story. All right. Knowledge check. So which of the following is a component of the spirit of MI? Select all that apply. A, partnership. B, engaging. C, planning. D, compassion. Or E, acceptance.
A, E.
Perfect. Yep. A, D, and E. Partnership, compassion, and acceptance. So language of change, we want to provide motivation, of course. So assessing motivation. So as I mentioned a couple times yesterday, we want to utilize that scale. And so when we ask our patients our questions, instead of saying, are you motivated? That's not helpful. They'll say yes or no, and you won't have a good understanding or a way to quantify it. But if we utilize the scale, it can give the patient an opportunity to think through kind of like, if I had to guess or like think through it, this is kind of where I'm at with my smoking cessation. So as a provider, you can say on a scale of 0 to 10, with 0 being not at all motivated to give up smoking, and 10 being I'm 100% motivated to to give up smoking, what number would you give yourself at this time? Let's say a patient says 4. This is when you can use those motivational statements. So why would you give yourself a 4 and not a 1? Gives you an opportunity to understand why they are more motivated and kind of what are their motivations. And then you can reverse it and say, why would you give yourself a 4 and not a 7? That gives you an opportunity to understand their barriers. What are their concerns, or why do they think that they're not quite there yet to quit? And you can utilize that to create a plan to help them overcome those barriers. And then you can ask additional questions of what is it about smoking that concerns you? So you can understand what is their motivation to quit. And a lot of times it's things along the lines of health risks, certainly. But it may also be like, I'm concerned that my daughter's learning these habits and I don't want her to be a smoker when she grows up. So you can use those as additional goals so that they understand. Yep. Planning is not a part of the spirit of MI because it's more of like an or skill. It's not, when we talk about the spirit of MI, it's these 4 specific things: education, partnership, acceptance, and compassion. Planning is more so part of the fundamental process, but it's not a specific core value of the spirit of MI. Makes sense.
I'm thinking that everything sits around planning, because if you don't have a good plan, you probably will not be able to achieve anything.
Sure.
So,
yes, it's important to have a good plan, but when we talk about the core values of MI, it's just these 4 things. Because we want to make sure that we set ourselves up with these 4 components: partnership, acceptance, compassion, and evocation, so that it creates a safe space for the patient themselves. Planning is a part of the process, and we can utilize that itself in MI, but it's not the main focus. You could technically include planning without using motivational interviewing. Does that make sense? Like, I can always give you a plan on what we're going to do for your smoking cessation or for your cardiovascular risk, but that doesn't have anything to do with your, yeah. So it's outside of that. Okay.
I have a question.
Yeah.
How would you handle it was pretty clear there, how would you handle, in the middle of the scale, questions for motivational interview? The example that you gave went 3 numbers below, 3 numbers above, just to have the mental frame of the patient to think about, what pushed you down or what would push you forward. But how about if the patient comes back saying that they are 0 on the scale? Do you just move on? And how about 10? How would you handle the interview if it's a 10 or a 0?
Yeah, good question. If it's a 0, I would still ask, why did you give yourself a 0 and not a 3? Something that's reasonable. And so we can talk through what their concerns are and what their barriers are. It's hard to evaluate, the opposite end. Of course, you can't go to a negative number because that wouldn't really make sense, but you can ask them, you can move on past that and ask questions like, what is it about smoking that concerns you? So in those cases, I want to understand kind of what they foresee as a barrier and why they're not there yet. Because that kind of goes back to those, to understanding what their barriers are. At this time, that they aren't motivated at all. So asking them, or going under would be not helpful or useful at all because you're not motivated at all. So maybe this is not the best time for you to go through tobacco cessation. Likely someone who's a 0 isn't even going to come see me. Does that make sense? But that's when I would utilize my 5As and continue to utilize the 5As at each touch point with the patient. Because eventually they will go from a 0 to a 3. And that's progress. Does that make sense? And then for a 10, that's great. You're super motivated. So I would ask them, why are you a 10 and not a 7? So we understand what their goals are, what their motivation is. I don't need to convince you really, you're ready. You're 100% ready. We don't need to do anything. We just need to start setting up what are our goals and what's your motivation and make a plan from there. Okay, perfect. So then I also want to assess how confident they are. So same thing, same scale, same question. So how confident are you that you could quit smoking in the next 30 days? So it's important to be specific and give a number. If you just say how confident are you that you'll be able to quit, they'll say, oh yeah, I can. You haven't given them a timeline. So you need to be specific in what your question is. So even if it's in the next 45 days, that's fine. I just use the next month as like a round figure and something easier for patients to quantify a month time. So how confident are you that you could quit smoking in the next 30 days on a scale of 0 to 10, with 0 being not at all confident that I can give up smoking and 10 being I 100% can give up smoking? And so if the patient says something like 5, my questions to them are, why would you give yourself a 5 and not a 2? Once again, understand what their barriers or to this lack of confidence in their ability to quit is. And then why would you give yourself a 5 and not an 8? In order to understand, yes, the barriers in that instance reverse. And then 5 and not a 2 so that we understand what their motivations are. And then in those moments, you can work with the patient to brainstorm ideas and provide information on what has worked for other patients or what clinical data you have to help them be successful in their smoking cessation. So what has worked in the past? I ask patients, if you've had a former quit attempt, what worked in the past? What did you do that was helpful? And so we can utilize those techniques, but maybe tweak them a little bit so that you're able to be a bit more successful or add to them so that you are successful in your next quit attempt. Okay. Any questions? We're going to skip these. You've probably seen these before, would be my guess. All right. And feel free to watch them on your own time. So part 5, we're really getting into our pharmacotherapy. So first, let's talk about non-pharmacologic options. So there's behavioral therapy, which we've talked about, and we always want to make sure that we combine that with pharmacotherapy, as that is the gold standard. And then there are things like hypnosis and acupuncture. With hypnosis, there's very limited data to support its efficacy, and some data shows very minimal benefit. The other component is it's really important to make sure that patients understand they need to find a credible hypnotist to perform hypnosis. A lot of times right now, a lot of the people that will say, oh, I can perform hypnotism, it's a scam. So sadly, I've had patients say, like, I spent $300 to get hypnotized because I was going to quit smoking and it didn't work. Well, likely, part of it is I don't have data to tell you that it's actually beneficial. And the other part of it is that individual may not have actually been qualified to perform hypnosis. And then we also have acupuncture as an option. The data varies for that. So some data shows that it can be beneficial. But generally, there's not been any benefit shown for long-term use. So it's best to just utilize cognitive behavioral therapy because we know that has the most data behind it and backing to show that it's the most benefit, because we want to reframe those patients and redirect those patients' habits and barriers to quitting, versus these other options aren't really reframing or refocusing any of those things, just aids as an optional adjunctive therapy. First, we'll go over our nicotine replacement therapy, also referred to as NRT. All of these agents are either over the counter, or there's a couple that are prescription only. So our over the counter options are the nicotine patch, the nicotine gum, and the nicotine lozenge. And then the 2 products that are prescription only based is the nicotine inhaler and the nicotine nasal spray. First, we'll start with the nicotine patch. So in terms of a mechanism of action for the nicotine patches, the nicotine itself binds to the nicotinic acetylcholine receptor and elicits that same response that we would see in that dopamine reward pathway. So it'll allow a release of dopamine, so the patient will have that feeling of pleasure without having any of the harmful toxic components that are in cigarettes. In terms of dosing, the dosing is dependent on how many cigarettes the patient smokes. So let's say the patient says I smoke 11 cigarettes, then in that case, they would need to start on the higher dose. So for patients that smoke greater than or equal to 10 cigarettes, we start with a 21 milligram patch for 6 weeks, then 14 milligram patch for 2 weeks, and then 7 milligram patch for 2 weeks. For patients that smoke less than 10 cigarettes, we start with the 14 milligram patch for 6 weeks, and then we drop down to the 7 milligram patch for 2 weeks. In terms of adverse effects, what we often will see are things like skin irritation, which can be avoided. So in terms of a counseling point for patients, we tell them that they should rotate the site of the nicotine patch. So they want to make sure that they place it somewhere on their upper body, but rotate the sites. So I tell patients, if you put it on your left arm one day, move it to your right arm, then you can move it up to your right shoulder the next day, and then over to your left shoulder the next day. That helps minimize that skin irritation that patients experience as a side effect. Other side effects that patients can experience include insomnia and vivid dreams. This also can be mitigated by telling the patient to remove the patch prior to bedtime, and then they'll be able to sleep all the way through. However, the patient can wear the patch all day and sleep with the patch on. And the only time I tell them to take it off is if they do experience that insomnia or vivid dreams. Other side effects that patients can experience include headaches, feelings of anxiety, as well as arrhythmias. So I counsel patients on all of these so that they're aware and tell them to let me know if any of them occur so that we can work through and talk through them.
What's the problem with having vivid dreams?
What is the problem with having vivid dreams?
Yeah. Why is that an issue?
Sometimes the vivid dreams are nightmares and they're not fun. So we tell them that they're vivid dreams so that they're not alarmed. Sometimes the vivid dreams elicit themselves in different ways, but then it causes difficulty for the patient to sleep if they have very vivid dreams, and it'll interrupt their REM cycle. Yeah. All right. The nicotine gum and lozenge, same mechanism of action as the nicotine patch. In terms of dosing, it's dependent on when they have their first cigarette. So if they have their first cigarette in less than 30 minutes of waking, then they get the higher dose of 4 milligrams. But if they have their first cigarette in greater than or equal to 30 minutes, then it's 2 milligrams. So that's why it's also very important to ask that question of how soon after you wake up do you have your first cigarette. Some of the adverse effects that patients can have with the nicotine gum and lozenge include headache, nausea, dyspepsia, heartburn, and oral irritation. I always tell patients, just let me know if you have any of these, and then we can talk through them. But a lot of the nausea and heartburn that patients experience has to do with with swallowing any of the saliva that they produce while using the nicotine gum or lozenge. So if the patient utilizes the products appropriately, they shouldn't have any of the nausea or vomiting. But if they, for example, if they chew the nicotine gum like regular gum, they will produce a lot of saliva. They'll swallow all of that and it'll go straight to the stomach. And as I mentioned yesterday, mentioned yesterday, nicotine is an irritant to the stomach, and that's part of the reason that it also causes that skin irritation. In terms of clinical pearls, so it's very important to tell patients don't eat or drink any acidic beverages or have any acidic meals around within 15 minutes of using the nicotine lozenge. And that's just because it decreases the efficacy of the nicotine gum and the nicotine lozenge, and they won't get the most benefit out of it. So patients, for example, will say, I have a cigarette with my coffee, and so can I use a piece of nicotine gum while I'm drinking my coffee? The answer is you shouldn't. They could, but they just won't get the most effect out of that product. So I always tell them, have your coffee, then wait 15 minutes, and then you can use the gum. So in terms of using the nicotine lozenge or gum, as I mentioned, there's specific ways that we want the patient to utilize them. So with the gum, we tell them to chew the gum until they have a peppery, tingly taste. And then we tell them to park it. So park it means just let it sit between your cheek and gum and let it just sit there. And then over time, they'll notice that peppery, tingly taste has started to go away. Once they notice that it's gone, they should start chewing the gum again. It reactivates the nicotine and gives them another dose, essentially. And once they notice that peppery, tingly taste returns, then they should let the gum, they should park it again and let it sit between their cheek and gum and continue that process until it no longer gives them a peppery, tingly taste when they chew it. And that's usually within 30-ish minutes. It's also important to let patients know that the max number of pieces of gum they can use in a day is 24, so they can use one every hour that they are awake. I always advocate and tell patients you can use up to 24, so you should. The only important thing to mention to them is that they can't double up, so they can't use more than one piece of gum in 1 hour. Then with the lozenge is a little bit different from the gum, obviously, because we don't want them to chew that. But we want them to place the lozenge in their mouth and allow it to dissolve slowly. They'll notice a peppery, tingly taste that may occur. And they want to make sure that they move the lozenge around occasionally, but also minimize swallowing because, like I said, it's an irritant to the stomach and will cause upset stomach and nausea and heartburn and things like that. We also want to make sure that they know to not chew it or swallow the lozenge. With the lozenge, the max number is 20 lozenges a day. So that's almost 1 an hour throughout the day. Most patients will not use the max, but it's important to make sure that they know that they can use that many because sometimes they get concerned. They're like, I don't want to use too many. Well, in this case, unless you double up in that hour, you'll be fine. No concerns of too many. Something that I always tell my patients, and it's really important in smoking cessation, is that when they're first starting to use the nicotine gum and lozenge, when they're first starting smoking cessation, to just schedule it. So you'll see on the box, it'll say use as needed. And in this case, I don't recommend to use as needed. I say use one every 1 to 2 hours scheduled. The reason we do this is so that we can get ahead of the cravings. If the patient waits until they have a craving start and they say, I think that I might be able to get through it without anything. And then they say, I don't think I can get through this. And they use one of the pieces of gum. It takes about 5 minutes for them to have any activity. And so do you think a patient will wait 5 minutes if they're having a really bad craving? No, they're not. They're going to throw that piece of gum away and say, it doesn't work, and I'm just going to have a cigarette, right? And it's not that it doesn't work. It's this that we let the craving get too far. So I just tell them we're just going to schedule it for probably the first 6-ish weeks, give or take, and see how you're doing. We might be able to do 4 weeks depending on how their progress is going, but I tell them we have to schedule it initially because they have to, for them to be successful, they have to use a minimum of 6 pieces of gum a day. If they use anything less than that, they're probably not going to be as successful as they could be. Mm-hmm.
As a patient, I can use up to 20 a day.
Mm-hmm.
At 6 p.m., I've used only 4.
Mm-hmm.
At 6 and 10 p.m., I want to do the remaining 14.
No, you can't double up within that hour. In order to get 14 in, you would have to use a few every hour. And so you can only do 1 every hour. If 6 p.m. hits, you can do up to 4 more between 6 and 10. Make sense? Perfect. Okay, so we have the nicotine nasal spray. Same mechanism of action. It's just nicotine, so it will bind to the nicotinic acetylcholine receptor, providing that release of dopamine. In terms of dosing, they can use 1 to 2 doses per hour. 1 dose is equal to 1 spray per nostril. And the max, and the dosing is 8 to 40 doses per day, with the max being 5 doses per hour or 40 doses in a day. Side effects that patients can experience include headache, rhinitis, flu-like symptoms, and cough, and that just has to do with the fact that it is a nasal spray. In terms of how to use the nasal spray, so it's important to let patients know that they need to prime the nasal spray before using it. If the product is new, they want to pump the nasal spray 6 to 8 times until they see a fine mist. And then if it's been just greater than 24 hours since they've used it, they can just pump it 1 to 2 times and they'll see a fine mist after the second time, first or second time. In terms of how to use it, so you want to tell the patient to clear out their nose, to blow their nose prior to using it. Then they want to tilt their head back, insert the tip of the nasal spray into their nostril, breathe through their mouth, and instill 1 spray in their nose. It's important that you tell the patient do not sniff, swallow, or breathe through your nose while instilling the nasal spray, because where the nasal spray is absorbed is through just the nasal passage, like through the mucosa in your nose. It is not absorbed through your sinuses. They will not get any benefit if they breathe it in. And then you just tell the patient, now you just have to wait 2 to 3 minutes before you blow your nose. And then after that, if they want to blow their nose, they can. So just an important piece. In terms of the use of this, some patients don't really like this because it's just a lot of work versus the nicotine nasal spray or nicotine gum and the nicotine lozenge. So I tend to go towards that first prior to offering the nasal spray, but it's certainly a good option. But remember that this is a prescription. So they'll have to get this from a prescription from a provider. Then we have the nicotine inhaler. Same mechanism of action. In terms of dosing, it's 1 cartridge every 1 to 2 hours. And they can use 6 to 16 cartridges per day, with the max being 16 cartridges per day. Adverse effects that they can see include cough, oral irritation, and nausea. However, it is discontinued in the US. I only teach this because patients can still get this in Canada. And patients will go get it in Canada. And so it's important to at least know, what the dosing is and what some of the adverse effects are, because you could have patients come to you to ask you about it. But generally, they will not be able to purchase it here.
Why is that?
The reason that they can't purchase it here is because there is a resin that is needed to manufacture it, and they can't get it in the US anymore. So they just took it off the market. However, Canada still has the ability to obtain that resin. All right. So looking at the nicotine plasma concentrations, I bring this to your attention because it's important to understand what the effect of the products that we're recommending to patients are. So if you look at the orange line, you can see that is the concentration that patients will get with cigarette smoking, right? They get this big spike, very large concentrations in the bloodstream. And then when you look at the nicotine gum and the nicotine lozenge, they get a very similar to what you would see with smoking. It takes a little bit of time for the gum and the lozenge to elicit a response, but they'll get a large spike and then it'll level out. And that's just essentially the gum and lozenge are no longer working at that point. But when we look at the nicotine patch, it provides sustained release over time, right? And so it's important to have that understanding because we can explain to the patient, it's very similar to what you would consider, right, with some type of sustained release product. And so it'll give them some type of nicotine release throughout the entire day, whereas our lozenge and nasal spray will provide them large doses similar to what they would get concentration-wise with smoking a cigarette. Not as large, of course, not as much of a concentration as you would see with smoking a cigarette, but a similar dosing, so that you would see a big spike and then it levels out. Okay. And this will become important when we talk a little bit more about our pharmacotherapy or our advanced pharmacotherapy perspective. So other options that we have with smoking cessation aids is that we have something called varenicline or Chantix. So the mechanism of action for this is it is a partial alpha-4 beta-2 nicotinic receptor agonist. And so it will bind to that receptor. As I mentioned, that's an important, earlier in our lecture, that's an important receptor when we talk about nicotine. And in that instance, it will provide a similar release of what we suspect of dopamine and serotonin to provide them that similar feelings of pleasure and joy and happiness and dopamine reward. In terms of dosing, it is titrated. And the titration schedule is for day 1 through 3, it's 0.5 milligrams per day. For days 3 through 7, then we go to 0.5 milligrams twice daily. And on day 8, we then do 1 milligram twice daily. The reason it's titrated is has to do with the side effect profile of it. If we give them, the full dose of 1 milligram twice daily, patients will likely experience a lot of side effects. And actually the studies show that they experience a lot of side effects. So it's very important to titrate up. And it helps mitigate one of the big side effects that I'll talk about in just a moment. In terms of clinical pearls, I tell patients it's very important to take this with a full glass of water. If they don't take it with a full glass of water, they will definitely experience a lot of nausea, which is one of the side effects of this medication. It's a very big side effect, and it's part of the reason that it's the big reason that we do titrate up to the goal dose. And then we want to be mindful of renal dose adjustments. This is renally cleared. And so if a patient has a creatinine clearance less than 30, we recommend that the initial dose be 0.5 milligrams daily with a max dose of 0.5 milligrams twice daily. We never want to titrate them up to the full dose because they will experience a lot of side effects. Okay. In terms of adverse effects, like I said, nausea is a big one. And we want to just make sure that we educate the patient to take it with a full glass of water and make sure that they titrate up to the goal dose of 1 milligram per day. If, let's say, they get to 1 milligram and they're experiencing severe nausea, you can certainly back down on the dose back to the 0.5 milligrams twice daily, if that is something that they were able to tolerate better. Other side effects include vivid dreams, insomnia, and depressed mood. With the vivid dreams, I do tell patients that they need to report that pretty immediately because it could range on what type of vivid dreams. I've heard a range of vivid dreams. I've heard things like I've had severe nightmares that were very bothersome and very troublesome. And so in those cases, I tell them that we just have to stop because it's just concerning for the patient. But sometimes I've heard things that patients will say, the vivid dreams were just psychedelic in nature. And they were like, they're not off-putting, they're not scary. If anything, I think they're funny. For example, I had a patient tell me that she had a dream that Snoop Dogg she was serving Snoop Dogg at a diner. I was like, oh. She said, it doesn't bother me though. So she's living her best life. And so we just worked through it and she was fine. So some of the side effects that you can see with varenicline. Just to know, there is no brand Chantix on the market anymore. Okay. So patients may say that, oh, I'm here to pick up Chantix, but it's only brand. It's only generic. Brand was taken off the market about 4 years ago. All right. Next option is bupropion, SR. The brand name for smoking cessation is Zyban. However, Zyban is also not available commercially, so you'll just dispense bupropion SR. Dosing is, mechanism of action, unknown. They have no clue, actually. So when this was studied for depression, they found that patients that were smokers just had an aversion to smoking. They were just like, I'm not interested, but they have no clue why. They suspect it obviously has to do with neurotransmitters, dopamine, serotonin, things like that, but it's not 100% known exactly what happens. In terms of dosing, this is another one that we want to make sure that we titrate. So on days 1 through 3, the dose is 150 milligrams daily. And then on days 4 and beyond is 150 milligrams twice daily. Adverse effects that can happen include insomnia, nausea, and dry mouth. There are a few contraindications, and so these contraindications include patients that have seizure disorders because bupropion can lower the seizure threshold, and so it puts a patient that has a seizure disorder at a higher risk. Let's see. Other thing to be mindful of is patients that have a current or prior diagnosis of bulimia or anorexia nervosa, and then any patients that have had abrupt discontinuation of alcohol or benzodiazepines, with the biggest concerns being like they are at a higher risk of developing seizures in those states. So because it can lower the seizure threshold, it's contraindicated in that patient population as well.
Is this different to how Wellbutrin formulation works?
In terms of the mechanism of action?
Like the Syvan,
Oh, same thing.
same thing.
There's no different formulation-wise. They just, every drug through the FDA, in order to be, like, have a new indication, they have to give it a new name. That's like semaglutide, Ozempic, that's for diabetes, but then there's Wegovy for weight loss. They just give it a different name, but same formulation. Okay, so the Eagles trial. So this is just like a pivotal trial in smoking cessation, specifically for smoking cessation aids. So really the objective of the Eagles trials was to assess the safety and efficacy of smoking cessation aids in patients with psychiatric disorders, specifically varenicline and bupropion, because the concern was that patients that have any type of psychiatric disorder, they could be at risk of suicidal ideation. Because that is one of the other big side effects, or was at the time, for quite some time. That has been removed because of the Eagles trial. So prior to the Eagles trial, there was this big box warning saying should not be used in patients that have a psychiatric disorder because of this risk of suicidal ideation. But after the Eagles trial, which was the objective was to assess safety and efficacy of smoking cessation aids in patients with psychiatric disorders, this trial was able to conclude that there's no difference in psychiatric events between non-psychiatric and the psychiatric cohorts, meaning that we can now remove this box warning. So if you go and look this up, you will no longer see this. But I want to say, and this was recent. I was in pharmacy school. I'm not that old. 2018, I think, ish. 2018, 2019 is when the box warning was removed. So something to be mindful of, because you may still hear some of the older providers say, oh, I can't use this in my patient because they have a psychiatric disorder. That's not true. The Eagles trial debunked that, and so it's safe to use in patients. We just want to be mindful that we utilize it in patients that are more stable in their treatment and in their psychiatric disorders at that time. If there's any instability at the time, fluctuating doses, titrating, and things like that of their psychiatric medications, we might just hold off for that time and maybe utilize an NRT product until they are stabilized, and then we can reconsider varenicline or bupropion. Okay. All right. Knowledge check. So which of the following medications is prescription only? Select all that apply. A, nicotine patch. B, varenicline. C, nicotine lozenge. D, nicotine nasal spray. E, nicotine gum. B and D. I heard B and D. Perfect. Yep. So B and D, varenicline and nicotine nasal spray. Remember the other prescription products, smoking cessation prescription products include bupropion and the nicotine inhaler, which you can't get in the United States, but don't be surprised if you find patients that do get them. Providers can technically, some prescribers in the US can prescribe medications in Canada, so they could potentially obtain it that way. All right, great. All right, so going through advanced pharmacotherapy. So we have several different pharmacotherapy approaches. We have pre-quit NRT use, meaning we just recommend starting NRT prior to setting a quit date. Combination therapy, which is very important, and I utilize this for all of my patients for the most part. And then extended treatment. Combination therapy. So essentially, there have been studies that have been done that shows better control of short-term abstinence and more likely to target multiple receptors when we use combination therapy. Who is this best recommended for patients that are motivated, patients that are adherent, patients that are experiencing significant withdrawal symptoms, and then patients that have a high nicotine dependence. So remember, we talked about nicotine dependence, and these patients that have high nicotine dependence, which is a lot of the patients that I have, I recommend combination NRT or combination pharmacotherapy. So that could be combination NRT. So that's the combination of a long-acting plus a short-acting NRT product, which has been shown to have better abstinence in patients, and this is FDA approved. So if you want to use a nicotine patch plus a nicotine lozenge or gum, that would be reasonable, and that's often what I will start in my patients. The other option is to utilize maybe combination NRT plus bupropion, or utilize NRT plus bupropion, so you could try the nicotine gum with bupropion or something like that. However, there is limited data available to support efficacy. It is FDA approved, though, to use bupropion plus NRT. So it's still an option. Data varies, but is not wrong at all, and still, like I said, targets multiple pathways so that patients are successful. Then finally, we have varenicline, which also has limited data that shows the treatment is safe due to some of the side effect profiles. However, it does have very good outcomes. So in these cases, you can use varenicline plus NRT, which was seen to be superior than NRT alone. But as I mentioned, one of the big side effects for varenicline, right, is nausea. And depending on which NRT products we use, we also want to be mindful of nausea as well. So you just want to be mindful and monitor for side effects when you utilize varenicline plus NRT. Typically, this is combined with a short-acting NRT, and so that's why I mentioned the nausea specifically, because remember, a big side effect of the nicotine gum and lozenge can be nausea. Some of that has to do with making sure that the patient is utilizing the products appropriately. But something that also is a side effect of varenicline, so we want to just monitor, and if that becomes bothersome for the patient, then we just have to switch up our plan. This is just to show you some of the success rates with combination therapy. So as you can see, placebo had 13.8% abstinence rate. When we look at varenicline alone, we have 33.2% abstinence rate. And then when we look at the long-term patch plus gum or spray, we have 36.5%. And then the patch plus bupropion is 28.9%. But everything listed here, for the most part, the highest ones are the combination therapies when you compare them to NRT alone, apart from varenicline, which has been shown to have very high abstinence rates. Okay. Then we also have extended duration of therapy. So as I mentioned, you probably saw with the nicotine patches, they all have like these very strict dosing guidelines, 14 milligrams for 6 weeks and then 2 weeks for the 7 milligram patches. Often in practice, we don't do that. This is mainly because some patients aren't as successful with such a stringent timeline. And so the rationale behind this is that less patients are motivated to self-quit. And so approximately 3 to 4% of patients can actually self-quit. And so for that reason, there is this recommendation that extended duration of therapy will provide them more time to wean off of, to get used to those withdrawal symptoms and get past the withdrawal symptoms. That can last between 6 and 8 weeks, generally. With NRT, there was a meta-analysis that was done that found an improved abstinence in patients that received treatment for greater than or equal to 12 weeks of therapy. And then with bupropion, there was also a meta-analysis that found improved abstinence when compared to standard of care when we did this extended duration, so greater than or equal to 12 weeks. And the randomized controlled trials for varenicline also had the same outcome. So essentially, all of this just goes to show that patients that have extended duration, so greater than or equal to 12 weeks, have better outcomes. Typically, this is done by doing 6 months of NRT or some type of therapy, and then sometimes, for the most part, we do an additional 6 months, or we do a first first 12 weeks and then additional 12 weeks for a total of 6 months, of therapy. And then at that point, we will decide whether or not it's best to come off of therapy, switch therapy, or if they should continue something for a little bit longer to help control some cravings and breakthrough. So typically, all of this is say duration of therapy is about 3 to 6 months. If your patient has quit after 3 months, then we do an additional 3 months just for an additional washout period or whatnot, just to make sure that the patient is has fully had time to adjust from their withdrawal symptoms and has been able to be successful in quitting. All right, so I know I mentioned earlier we talked about e-cigarettes. I wanted to bring this up because this was recently published in the New England Journal of Medicine. It was the ESTEN study that assessed the use of e-cigarettes for smoking cessation. So they compared e-cigarettes plus the standard of care versus the standard of care alone. And there were 2 intervention groups. The intervention group received smoking cessation counseling plus e-cigarettes in varied concentrations. And the control group received smoking cessation counseling plus smoking cessation aids. They just wanted, the primary outcome was just to assess continuous abstinence from tobacco smoking for 6 months. Then they had a few secondary outcomes that I have listed here. The results of this trial showed that essentially smoking cessation counseling plus e-cigarettes yielded a statistically significant abstinence from tobacco smoking compared to control groups. All of this to say that based off of this study, they say that it's useful to utilize e-cigarettes to help and aid in smoking cessation. Now, keep in mind that this is a short-term study. And so this was 6 months, right? And so as I mentioned, most people, when they try utilizing e-cigarettes, they end up on it long-term if someone's not monitoring. So with this was a controlled environment. They were able to be on this product and hopefully stop at the end. But this study just says for short-term use, it's efficacious. Doesn't say too much about safety. We don't know what that did to their lungs short-term, but it did get them off cigarettes. And that just goes to show that for a short-term benefit, there could be some use there. However, the data for long-term safety and efficacy is lacking. So for that reason, I still don't recommend e-cigarette usage for patients. Mm-hmm.
This study, when it says it gets them off tobacco, would that mean that they left tobacco and went to e-cigarettes? Or they left tobacco and e-cigarettes combined?
They have to be off of cigarettes, like no for traditional cigarette smoking.
They probably went to e-cigarettes.
They had to go to e-cigarettes, I guess. What do you?
What I'm asking is, I thought what we are trying to do is to stop them from other e-cigarettes or any kinds of smoking.
Mm-hmm.
So if they migrated from traditional smoking to e-cigarettes, would we achieve anything in the study? So I wanted to understand that.
Oh, yes. The goal is that this was short term. So this was only for a 6 month trial period, and the goal would be they would completely stop any form of inhalation at 6 months. And so they just use it as an aid, similar to like your nicotine inhaler that I told you is no longer on the product or on the market here in the US. So that's the way that they utilized it, and that's the way that e-cigarettes were created. It was supposed to be very short term. So even if there were some health benefits associated with it, they would hopefully be minor because of it being such a short-term time period. But they've turned into something that's used every day, long-term. All right, special populations and comorbidities. We're almost done. Special populations. So we have pregnancy, mental health and substance use disorder, and cardiovascular disease. So pregnancy risk while smoking. So smoking while pregnant increases risk of miscarriage, congenital anomalies, stillbirths, fetal growth restrictions, preterm birth, and placenta abruption. There were several studies that were done, and essentially they all found that behavioral therapy increased smoking cessation. Patients should work with their OB-GYN to determine the best course, NRT versus behavioral therapy alone. It's hard to say. For the most part, the assumption is that NRT is certainly more safe than smoking while pregnant, and so it's relatively safe, but the data is a little bit unclear. The studies do lean towards the benefit, like I said, because smoking is definitely more harmful to the fetus than that of NRT. However, these benefits were not shown to be statistically significant. So that's why it's important that the patient works with their OB-GYN. In terms of mental health and substance use disorder, so patients that have mood disorders, NRT plus bupropion may have some benefits to help with craving management as well as depression symptoms. So in those cases, that might be the best option for your patient. Patients that have anxiety, it's important to keep their NRT doses stable daily to reduce the fluctuations in nicotine absorption. And then, like I said, varenicline has now been shown to be safe in patients that have psychiatric disorders based off of the EAGLES trials. Something to be mindful of is there are some drug interactions that I have listed here that I want you to be mindful of. These drug interactions have to do with interactions with tobacco smoke and not with nicotine itself. So this all has to do with the smoke component because like I said, like I mentioned earlier, cigarette smoke contains polycyclic aromatic hydrocarbons, which can elicit a drug interaction with CYP1A2. And so for that reason, we would just want to be mindful when patients quit that their dosing of these medications that I have listed here may have to change and fluctuate because they are inhibited by 1A2. Now we have cardiovascular disease, which was also studied in the EAGLES trial. This assessed cardiovascular events in patients receiving smoking cessation aids. Based off of this study, that they found that there was no difference in cardiovascular events. So a lot of patients will say, if I utilize these NRT agents, I'm going to have a heart attack. That used to be a thing way back in the day. It's not true. The EAGLES trial debunked that and showed that these smoking cessation aids were safe and effective to use in patients that had cardiovascular disorders. Now, as I mentioned, there is that drug interaction with 1A2. It does also interact with several of our cardiovascular medications, so I want you to be aware of this. It interacts with things like warfarin, clopidogrel, propranolol, and flecainide. And it essentially decreases the efficacy of these medications, so often patients will need higher doses, especially with things like warfarin. You might see patients have higher doses, but as they tell you, oh, I'm deciding to quit, maybe they go from 10 cigarettes to 3, you'll see that their INR jumps up. And so it's important that the cardiologist is aware, as well as any practitioners, so pharmacists or anything along those, any healthcare practitioner that is aiding in the patient's care is aware that they're quitting so that they can monitor for things like bleeding, fluctuations, and toxicities with these medications. All right, now let's check. So which of the following is true for the treatment duration for smoking cessation? A, patients should receive pharmacotherapy treatment for a maximum of 8 weeks. B, the only pharmacotherapy agent that can be used for greater than 12 weeks is bupropion. C, there is no data available to indicate duration of therapy for therapy matters for smoking cessation. And D, all pharmacotherapy agents should be used for greater than or equal to 12 weeks. D. I agree. D. So all pharmacotherapy agents should be used for greater than or equal to 12 weeks. All right. So some take-home points for this lecture. So feelings of reward and relief relief of withdrawal symptoms is due to the release of dopamine. So remember that dopamine reward pathway. There are thousands of components in cigarettes, and many of these components increase the risk of developing cancer. As I mentioned earlier, there's greater than 9,000 components in these cigarettes. Remember that the 5A should be used at every visit, and we utilize these assessments as a vital sign. So at every touch point, we want to assess the patient's readiness to quit. Remember that the gold standard of treatment is combination of behavioral therapy and pharmacotherapy. And remember that combination NRT and combination pharmacotherapy as a whole is more effective than monotherapy. Okay. And with that, any questions? All right, so how about you guys take like a quick 5-minute break and then we can do the assessment. All right. Sorry, I shut it off.
So ready to be done. Also, while you guys are in the break, well, if you guys could go ahead and get set up, it's an individual assessment, so just go ahead and get set up with the appropriate seating of 2 seats in between people and skip a row. Yeah, so I pick today, tomorrow, just pick whatever time you want and respond. Yeah, you just tell me what time you want.
Yes, sir.
Like 10:30.
Around, we do it 10:15. It's open.
Good.
You know it's open.
Okay,
It shouldn't.
very easy.
It shouldn't. You did. It's just fine.
Did you get the Did you show?
Damn it, let's skip around. You turn them on.
Is this open?
Yes. You just learned it. Just learned it. It has to be open. Yeah.
No, he has a good
Yeah, if y'all went to my school, it would have been closed.
close note, but
If you went to school with us, it would have been closed. But we're nice with him. It's on Canvas.
Can we start?
When the break is over. When the break is over and when everyone's seated appropriately. Because you're not.
and can they ask questions? Okay.
So there should be a row skip. So if you're directly behind somebody or in front of someone in a row, y'all can talk with each other about who's moving because someone's moving. figure. Well, let me look it up.
I pedí personalmente.
What you got after that?
After this, we prepare to teach tomorrow.
I need the preparation.
I think tomorrow. And grade this. You sent the key, so I can.
And you might just have to refer to, because one of the questions was like literally anything outside.
Yeah. This one. Okay. All right, you guys. All right, you guys can go ahead and start. It's open note. You guys can ask us questions, and you're dismissed when you're done. It should be a file upload, so just upload the document.